Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. And we have a good topic today, legislative issues regarding patient and physicians of Delaware. And our guest today is Dr. Richard Henderson, who is the chair of the Legislative Committee. But before we get on with that, I'd like to do a little housekeeping. I'd like to give a shout out to our sponsors, WSFS Bank, the DIN, Delaware Health Information Network, the Platinum Group, the Fine Dining Group, Peak Technology, YMCA, SourcePass, and Curie Insurance. Anyone who has any questions, concerns, or anything they're worried about or want to discuss with us and or have ideas for future podcasts, please reach us at our email. That's healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. And the opinions expressed in this podcast do not necessarily reflect the opinions of the Medical Society of Delaware. They are strictly for information and education of our physicians and patients of Delaware and beyond. Today our guest, as mentioned above, is Dr. Richard Henderson. Dr. Henderson graduated from Fordham University before going to Howard University College of Medicine in Washington, D.C., earning his medical degree in 1980. Dr. Henderson's residency training was completed at Wilmington Medical Center, now called Christiana Healthcare, in Wilmington, Delaware. He practiced in the city of Wilmington until his retirement in July of 2020. Dr. Henderson is a diplomat of the American Board of Obstetrics and Gynecology and a fellow of the American College of Obstetricians and Gynecology. He has held many positions of responsibility in the local and regional organizations of FACOG, which is the American College of Obstetrics and Gynecology, including serving as the chair of FACOG District 3, including Delaware, New Jersey, Pennsylvania, and the Dominican Republic, and in 2010 to 2013, during which time he represented the District 3 of FACOG Executive Board. Dr. Henderson began his leadership at the Medical Society of Delaware, serving as vice chair and eventually chair of the Government Affairs Committee, spanning a 6-year period from 2012 to 2017, and again from 2019 to the present. He climbed the leadership ladder with his election to vice president in 2016 and president-elect the following year. And as of January 1st, 2018, Dr. Henderson assumed the seat of president of the Medical Society of Delaware, for which he served one term. Welcome, Rich. How are you, buddy?
Very well. Thanks for having me.
Oh, I'm glad to have you here. And now we're going to discuss legislative issues that you, Rich, have been taking care of for all the months previous. And now that the legislature is out on vacation, right, or out for the year, correct?
Not yet. They come back in on next week.
Oh, they do next week. For how long?
Till the end of June.
Okay, so they're almost on vacation.
Almost.
Okay. All right, the issues we're concerned about apply to both physicians and patients of Delaware. Let's talk first about Senate Bill 2 and Senate Bill 1, the rebalance of health care spending in Delaware. Go give me a talk on that one.
Primary care reform is one of the legislative priorities for the Medical Society, and Senate Bill 1 with Senate Substitute 2 addresses that effort. This legislation aims to rebalance the health care spending to invest more in primary care and build on previous primary care legislation that was passed in 2018 and 2021. The bill in 2021 was Senate Bill 120. Our primary care subcommittee has developed and advocated for key elements needed to build on improving primary care. That includes at least a 11.5% spend on the primary care investment, remove the current sunset provision in Senate Bill 120, which will sunset in 2027, include both Medicaid and the state employee health plans. That was not possible in Senate Bill 120. and address attribution issues to ensure investments follow the patient to their primary care practices, and establish a 5-year glide path within reimbursement at a fee-for-service rate of Medicare or a robust prospective payment model that would support the move to value-based care models versus expecting practices to bear the impact of those costs up front with no guarantee of reimbursement later. The original bill also included a 250% cap for hospitals that was very problematic in the previous legislation.
I know that was opposed by the hospitals at first, right?
It was House Bill 350 in 2025. It was vigorously opposed by the Hospital Association, and I believe that was resolved in court. Senate Substitute 2 for Senate Bill 1 addresses the concerns that the Hospital Association had with the original Senate Bill 1. Senate Substitute 2 passed in the Delaware Senate with unanimous bipartisan vote on May 19th of 2026. It's been assigned to the House Administrative Committee with action pending. In the May edition of the Legislative E-Update, it listed the members of that committee. I would encourage all of our physicians to check out that E-Legislative Update and contact those legislators as this moves forward.
Okay. Have the insurers gone along with this to increase reimbursement to the primary care doctors and, maybe take a little off the top from the hospitals? Have they gone along with that?
They have not opposed either Senate Bill 1 or Senate Substitute 2.
Great. That's nice to hear, me being a primary care physician. Okay, what about educational transparency? What have we had in the legislature regarding that?
So this has been an ongoing issue for the medical society. And when we spoke with our legislators about this, they asked for data on this issue, which we didn't have at the time, and that was one of the factors that may have prevented it from moving forward. The medical society worked with the Delaware Academy of Dermatology to secure a $70,000 grant from the AMA, the first for Delaware as I can recall, to address educational transparency and ensure a more transparent approach for the public regarding the education and training of the practitioners that they're seeing, as more and more non-physician clinicians are obtaining their doctorate level certificates and can use the term doctor.
Okay.
Using the AMA grant, the medical society engaged a public relations firm to collect data regarding public perception and understanding about the importance of title transparency.
Mm-hmm.
This firm conducted surveys in all 3 counties across all demographics and political lines to obtain objective data for our legislators to support the concerns that have been raised by the medical society about this issue over the years. If I could, I'd like to share a couple highlights of that survey.
Please do.
83% of those surveyed indicated that it's very important to know the type of clinician they're seeing. 80% believe it's very important to know the clinician's licensing, training, and education. 96% believe non-physician-owned practices should be required to disclose if there's not a supervising physician on site. 90% want legislation passed requiring disclosure if a clinician isn't a physician. This data has been developed into a static ad campaign that is being shared with legislators to help move this legislation forward. The Medical Society has also developed a title transparency bill and secured a sponsor in the Senate, but we don't have one so far in the House.
Okay.
It would be ideal if the Speaker of the House of Representatives, who is a nurse, would take this up. So far that hasn't happened, but our discussions continue.
Does she have a bias? The nurse that's the Speaker of the House.
She is the Speaker of the House.
Does she want her nurse practitioners that get their degree to be called doctor?
If they've earned their degree, I believe that was her intent.
But that's not being transparent that they are not physicians.
That's why we were pushing for title transparency.
Got it. Okay.
And this static ad campaign that I mentioned earlier is focusing on the Dover area. It began on May 20th. It ran for 3 days. and it focused around the Legislative Hall area. That campaign will resume early next week, again focusing on the area around Legislative Hall. And so far, I believe we've gotten some pretty good feedback from those that have responded.
Great. That's good to hear. Now, this is a bugaboo of mine. It's a prior authorization reform. In 2008, when I acted as president of the Medical Society, I put it in my platform that I wanted to see this particular process eliminated. The AMA has thrown statistics at us showing that it's way too costly, way too burdensome, and partly is responsible for physician burnout. So tell me a little about SB 12 and SA1, or with SA1.
Senate Bill 12 with Senate Amendment 1 passed during the 2025 legislative session and was signed by the governor, so it is now law. This bill would shorten response times, increase times authorizations remain valid, limit the number of requests to a single episode of care for clean claims, and make utilization review entities available beyond the typical 9-to-5 workday and available on the weekends. We are also looking into some other aspects that we feel would enhance prior authorizations, such as goal carding.
Explain that.
Goal carding is a process that exempts high-performing practices from the routine prior authorization requirements based on past approval histories. It has some clear benefits, faster patient access to care, treatments, and testing, and receiving medications. It reduces the administrative burden for clinical staff and saves significant time in paperwork and on repetitive documentation. It allows for reallocation of resources to allow practices to redirect clinical staff and capital away from the navigating the insurance process and more towards patient-centered care. And it incentivizes quality of care by rewarding practices that consistently comply with the evidence-based criteria, encourages careful documentation, and accurate value-based driven care.
Got it. Well, we're chipping away at prior auth, but it's still there.
It's still there.
It's always there. Okay. That was signed by the governor, right?
Yes.
Okay.
Last in 2025.
Okay. Now talk to me about Senate Bill 320.
Senate Bill 320?
Yes. It was introduced. I don't know if it's been acted upon yet.
Senate Bill 320 regards the pharmacy scope of practice. It was introduced on May 14th of 2026. This is part of a series of bills that required to be passed as part of the Regional Health Transformation Program that we'll talk about a little bit more about later. This bill would modernize the pharmacy practice laws by permitting the pharmacists to independently evaluate patients, identify health conditions, order and prescribe labs, and prescribe drugs or devices without reliance on a statewide protocol, formularies, or specific list of conditions. Pharmacists may not prescribe controlled substances, with the exemptions of medications for the treatment of opioid use disorder, which may be done only under a standing order from the Division of Public Health. The Medical Society's team has worked behind the scenes in a collaborative effort to make the following recommendations for consideration, because as written, we are opposed to the bill. Those recommendations including that any tests ordered and results obtained be reported to the Delaware Health Information Network so that the physicians involved in the care of that patient, once they are no longer involved with the pharmacy, have access to that information. The second would be that actions taken against the pharmacist be reported to the National Practitioner Data Bank, as is required for physicians, and pharmacists are under the National Practitioner Data Bank. And the third was to expand liability coverage to include the diagnosis and treatment. We haven't seen any amendments yet for Senate Bill 320, but have been told through back channel communications that reporting to the DIN may be included. It's interesting, as I mentioned, that pharmacists are included in requirements to reporting for the National Practitioner Data Bank for the same reasons that applies to physicians, that you don't want a bad actor moving from state to state without some identification. Currently, the Board of Pharmacy reports to the Division of Professional Regulations, which also has a portal that can be accessed at no cost to see if there have been any actions taken against pharmacists.
Do you think this bill will pass? We're opposed to it. I don't know what else we could put in it to voice our opposition. Whether it's another infringement upon our scope of practice. I do realize pharmacists know more about pharma medications than I do, but if it goes out on the DIN that they did a test, they treated a sore throat with amoxicillin, and I don't know that patient was seen by the pharmacist, I don't know how I would retrieve it from the DIN unless the patient told me they were there. Is there some way to, if it does pass, have that pharmacy identify me as the primary care doctor so that I can have it on my list of DIN information to read over daily?
Your patient would have to identify you as being their primary care physician,
and they would have to put it out as my patient. So in other words, on the DIN right now, my patient's information, I put it on there. I said,
correct.
Yes, they had this, and I get it. The pharmacist puts it out on the DIN. How am I going to get that?
Hopefully, well, not hopefully, there'll be some requirement that you be notified that those tests were done.
Got it. Okay. So we're opposed to it, and you're going to work with it to work it out a little bit. I see this as, we have a shortage of primary care doctors, and this is the way they seem to want to help with the shortage. And, a shortage is good, but a pharmacist is a pharmacist and a physician is a physician. There's a difference.
Well, this is one of two bills that are part of what's required under the Regional Health Transformation Plan.
Okay.
That's a $50 billion CMS initiative between 2026 and 2030. That's designed to strengthen healthcare access, workforce development, and technologies in rural communities across the country. It would provide eligible states with $100 million annually.
$100 million annually.
To design care delivery and improve healthcare outcomes and address the health professional care shortage areas.
That's the reasoning behind this bill, no doubt.
Yep. And the aim is to create long-term sustainable improvements in rural health infrastructure that support initiatives such as mobile and school-based health units, train here, stay here programs, and investments in IT infrastructure.
Gotcha.
That plan, the Regional Health Transformation Plan, has 5 strategic goals: to make rural America healthy again by creating new access points, using evidence-based and outcome-driven interventions to address the root causes of diseases and improve disease prevention. Number 2 is create sustainable access by helping rural clinicians become long-term access care points. As you mentioned, we have a shortage. The third is workforce development by attracting and retaining highly skilled healthcare workforce and by strengthening recruitment and retention of physicians and other clinicians in those rural communities. And the fourth is to support innovative care models, and 5 is to support technology innovations. To be eligible for the additional funding under the Regional Health Transformation Plan, legislation required to be passed to increase the scope of practice for nurse practitioners, PAs, pharmacists, and dental hygienists. So 320 addressed the pharmacists.
Okay.
House Bill 325 expands the scope for physician's assistants.
Yeah, they want to be able to practice the physician assistants on their own and without a doctor's supervision. Is that true?
That is correct.
We are opposed, I assume.
Yes.
Okay. So's the AMA, I believe.
Yep. Currently, the physician's assistants are the regulatory council for physician assistants is under the Board of Medical License and Discipline, and that would not change.
Okay.
What 325 proposes to do is change the name from physician assistant to physician associate. It would remove requirements for a collaborative practice agreement. It would grant independent practice privileges after 4,000 hours of postgraduate clinical training. The Medical Society proposed 10,000 hours, and the compromise was 6,000 hours, which was included in the bill. For those with less than 6,000 hours, it would require them to have a collaborative agreement. The physician assistant must apply to the PA Regulatory Council, which I mentioned is under the Board of Medical License and Discipline, for change in practice and provide proof of training that aligns with the new practice area that they may be interested in. So if a PA wanted to switch from orthopedics to dermatology, they would have to document that they have had the training and education to do so.
Okay.
It would also designate physician's assistants or associates as primary care for billing purposes with payments based on the services provided and not the healthcare professional who delivered it. This, I guess, would be on the scale of pay parity.
All right, let's another chip away at the profession. I see everybody wants to be a doctor, but I tell everyone that comes in, I train nurse practitioners in my office also. I give them their education. They need to be with me for 3 months from various places. And I tell them, why do you want to be on your own? Running a practice is very difficult and very expensive, and they all want to be, out there doing it. But to each his own, I guess. Now, how about Senate Bill 295, another scope of practice issue with the estheticians?
Yes, this is not part of the rural health transformation process,
okay.
But this would increase the scope of practice for estheticians. We at the Medical Society are opposed to this.
What do they want to do?
This bill adds to definitions to update the scope of practice for estheticians, as the current scope of practice doesn't encompass all the services they provide or their education and training. It would provide clarity to professionals and the public as to what treatments are permissible and the specifics that an esthetician, got to say that 5 times fast, is able to perform as subject to meeting the training requirements and manufacturer's directions. There are about 16 different procedures or treatments that are listed in the bill that would increase or change the scope of practice for this particular group. 3 things would be prohibited: the diagnosis of illness and disease or injury, performing ablation of the dermis or hypodermis, and prescribing meds or providing medical treatment in the same manner as a dermatologist. So they do recognize there's a difference between that group.
Agreed.
Working with the Delaware Academy of Dermatology, several significant clinical and regulatory concerns were noted. One is the unregulated, non-ablative skin rejuvenation treatment or procedures. The bill contains contradictory and dangerous microneedling depths, permitting high-risk chemical peels and contradictory pH limits, which could lead to significant patient injury and complications, and authorization of ablation, and the broad catch-all language used in describing some of these procedures. Because of these concerns raised by the Delaware Academy of Dermatology and the Medical Society, this bill was pulled from committee and is not expected to move forward for the remainder of this session.
Very good. All right, at this point in time, I'd like to take a brief break and have our producer, Tom Minton, discuss our very generous supporters.
The Platinum Dining Group is a full-service hospitality group based in northern Delaware and founded in 1996. They are a company that believes the very fundamental truth that no task is too great and no detail too small. Eclipse Bistro, 7 restaurants, and any event catering company and a fine goods retail market now reside under the PDG umbrella. They strive, with one guest at a time, to offer a complete and rewarding hospitality experience. We're pleased and proud to have Platinum Dining Group as a sponsor of the Medical Society of Delaware's podcast series.
Hi, it's Dr. Nick Biasotto back from our break talking to Dr. Richard Henderson regarding legislative issues affecting the patients and doctors of Delaware. All right, Rich, how about Senate Bill 22? That's one I'm interested in hearing about too. The Fair Standards in Mental Health Care Act.
This has been viewed by the AMA as being model legislation to improve mental health care here in the state. We are in constant contact with the AMA regarding this and working with this bill sponsors to address any issues that they may have.
Okay. Now, I'd just like to add something. Back in the day, in Kennedy's era, we got elimination of asylums, as they were called, because Thorazine was discovered, thought to be the miracle drug for mental illness. Didn't turn out to be the miracle drug, and we still have a problem with mental health in this country. Parity is not there. Mental health people hardly get reimbursed properly for all the time they put in. We don't have areas in each of our 3 counties to deal with the mental health issues of those counties. I said, why not? There's some people you can cure or help significantly with medication, but there's some mental illness that we can't. Is there any way we can have the development of the asylum situation back, i.e., one asylum in each county to take care of those that we can't take care of and allow on the streets even, because they would just live on the streets? I don't see why we can't put an investment in something like that. They don't have to be huge buildings, but they have to be at least like hospital-like buildings in each county. But that's my opinion. The AMA thinks that we have a great bill. It's a model bill. I agree. It's doing something to take care of mental illness in the state of Delaware, but I think we need to do a little bit more than just placate the legislature. So I hope that happens somehow, some way. Some states have so many people living on the streets. It's incredible. And most of them have significant mental illness or drug abuse. So they can be rehabbed somewhere and put back in the street in a healthier condition. Okay, how about House Bill 422?
House Bill 422 has to do with vaccinations. It requires an enhanced informed consent process before vaccines can be administered to infants under 12 months of age. It will require clinicians to discuss the possible side effects, discuss the overlap between vaccines given in a 2 to 4 month window, and explain to patients how to report events to the vaccine adverse event reporting or file a vaccine injury compensation program claim. DHSS would be required to design an acknowledgement form that would be signed by the parent. It would mandate that vaccination history be documented on every sudden unexplained infant death or sudden infant death syndrome investigation to support accurate cause of death determinations. The Medical Society has collaborated with the Delaware chapter of the American Academy of Pediatrics to strongly oppose this bill because there are already requirements in place regarding disclosure before vaccines are administered, and this creates another level of duplicative and unnecessary requirements and documentation. Perhaps more importantly, it also creates public doubt in the safety and efficacy of vaccines, as well as creating a link between childhood vaccinations and poor outcomes that evidence-based studies have shown does not exist.
Okay.
Along with the Delaware chapter of the American Academy of Pediatrics, the Medical Society opposes this bill. It has not come before, has not been assigned to committee for hearing at this time.
Okay. Another twist on some of the federal investigations regarding vaccines and the controversy that exists with vaccines. Okay, how about Senate Bill 334, streamlining the credentialing process?
That is the intent of the bill. It would require carriers to participate in a uniform credentialing process with defined timetables and create a speed to market for healthcare professionals. Currently, healthcare professionals, as you know, may be employed for 6 months or more with no ability to collect reimbursement for services that are rendered due to the lengthy carrier credentialing process. Mm-hmm. Uniformity across carriers would be beneficial for both patients and practices. Under this bill, the credentialing process will be limited to 45 days versus the current 90 days. The 45-day limit would benefit healthcare professionals across the spectrum statewide, including federally qualified health centers and designated health professional shortage areas in primary care and dental care in both Kent and Sussex counties. More than 30 states have credentialing standards and laws that this is attempting to mirror. Components of this legislation are also derived from the National Association of Insurance Commissioners Healthcare Professional Credentialing Verification Model Act. So the Medical Society has been working with the Department of Insurance on this for several months, and we'll be discussing it further now that it's been formally introduced.
Okay, very good. All right, a little bit about Senate Bill 13. I think it's on the docket somewhere down the line, if you have that information available.
So Senate Bill 13 is a very large bill with 7 sections. It seeks to create a process for charity care billing in the state. In summary, this could be considered landmark legislation here in Delaware, designed to expand hospital charity care and shield families from overwhelming medical debt. It will completely overhaul the rules regarding our current nonprofit hospitals, in that they must provide free or discounted care and treatments. It would establish a statewide standardized criteria tied directly to the federal poverty level. For those at less than 300% of the federal poverty level, general acute care hospitals must provide 100% free care. At 300 to 350%, hospitals must provide at least a 75% discount. At the 350 to 400% level, hospitals must provide at least a 50% discount. And up to 500%, families experiencing a medical hardship where medical expenses exceed 10% of their household income would be qualified for a 50% discount. This is also ongoing through the legislature. In our discussions with the Office of the Governor, it has been indicated that this is a priority for them. So I'm sure we will hear more.
I'm sure we will. It sounds like a real good plan to me. We have in our association here at the Medical Society the VIP program, in which those that sign give a sliding scale type of payment towards patients who cannot afford to get insurance, etc. And I have VIP patients that I've seen in the past and continue to see that more or less I do it gratis because they can't afford it.
And that's one of the programs that we have highlighted in discussions with the governor's office in attempting to make that a more formal link.
Great.
So that it gets, can expand it to a broader population.
Great. Anything else, Rich? I don't have any on board. Do you?
No, but if I could, I'd put a plug in. Say thank you to the members of the Government Affairs Committee who meet from January to the end of June for the legislative session. Come back in the fall in preparation for the coming legislative year. I'd like to thank Mark Thompson, Lisa Gruss, the Medical Society staff for all the support that they've given to the Government Affairs Committee that makes doing this work a whole lot easier.
I understand you're retiring at the end of the year from the chairmanship.
I will be stepping down as chair, and Dr. Sheehan, who's been on the Government Affairs Committee for a long, long time, will become chair.
Very good.
And Cedric Barnes will become vice chair starting in January of 2027, which will start a new 2-year legislative cycle.
Going to miss you, Rich. Going to miss you.
I'll still be around.
I know you will. All right. This is Dr. Nick Biasotto completing our podcast with Dr. Richard Henderson regarding legislative issues coming out of Dover. We'll be back with more coming up in the future, so please keep on listening.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to Audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts for any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.